Welcome, guys. Just a couple of things before we get started. You're on break. I am not. I don't think that's fair, so I am going to pout and stamp my little feet and torture you with a lot of slides. Secondly, my day is quickly getting away from me. There's no way I'm going to get this entire unit done today, so you'll probably be broken into parts, and it will be coming soon to a Moodle site near you. This would be part one, of course. We're starting patient assessment. Actually, we already started patient assessment. We were talking about in the previous units parts of patient assessment. Scene size up is a part of patient assessment, and of course, vital signs and monitoring are a part of patient assessment. We're going to talk about these things in context. We're going to talk about in this particular section scene size up again briefly, primary assessment, your secondary assessment, and focusing mostly on stable and unstable trauma patients and responsive and unresponsive medical patients, and then reassessment. I'm going to go ahead and probably do a preemptive apology about the sound quality. It's been a while since I've recorded, and I recorded a lecture, and I've never recorded one on this particular computer, so I'm trying to make sure our sound quality is such that you can actually hear this. Our case study this time, we have ambulance 12 has just been dispatched for a report of an injured person who fell from a ladder. Talked in class about a ladder case that I told you about. EMTs Carrie Pace and Della Larson arrive on the scene, parking in front of the residence. Carrie and Della take a moment to look around and observe the scene prior to approaching on foot. As they exit the ambulance, a woman comes back around the side of the house saying, "He's back here. I think he broke his arm and he's diabetic." The EMTs follow the woman into the backyard. And our case study questions, the first of them, and we'll come back to some more, I'm sure. What observations of the scene should Carrie and Della make as they walk toward the patient? And what observations of the patient should Carrie and Della make as they approach the patient? You can cut the video off and give us some thought if you'd like. I'm going to go ahead and say the first observations that I would be looking for. It just popped into my head. What surface is the patient lying on? Another one is, are there objects above me? How close he is to the ladder? Am I under the ladder? Was he working on the roof? Is there things on the roof going to fall on my head? Things of that nature. And as far as the patient, I would be thinking about, what obvious injuries do I see? How is he lying? What is the position of the patient tell you about the possible injuries? We talked at length about mechanism of injury. We know it's a fall, but you can also get some clues to exactly what it might have been contacted on the way down. There's a lot of things you can think about with this, and I'm sure we'll explore them all as we go through this particular unit. Don't have to beat this up. If we don't assess a patient, we can't treat a patient. And our treatment is only going to be as good as our assessment. We talked about some of the challenges of patient assessment, and I'm probably sure they'll be here again. But assessment includes the scene size up, which we've talked about at length, because injured EMTs are not going to help anybody. And primary assessment, which is your life-sustaining assessment. This is where we rapidly assess the vital systems necessary to sustain life. And then our secondary assessment findings, and then a reassessment. Reassessment often gets shortchanged. We do it once, and we sometimes forget to go back to it. But we need to continually reassess our patients. One of the pieces of information that's important to a hospital is not only where a patient's condition was when we found them, but where it went. Did they get better? Did they get worse? And we only know that if we reassess. Scene size up. We're going to move through this pretty quick. We've already talked about it. You're always sizing up a scene. You size it up when you approach for any immediate hazards or any potential hazards. But as I've said many, many times, you're probably sick of hearing me saying it, scenes are dynamic. They change. They're not all one thing all the time. They can be safe initially and become unsafe, and it can happen faster than you can imagine. It can happen when you least, and usually does happen when you least expect it, and it can come from a source that you least expect. Maybe it's a patient, maybe it's a family member, maybe it's a bystander. It could be a number of things. There are operational and patient care aspects of a size up. Our previous case study hinted at some of that, and part of our assessment right from the outset is determining the mechanism of the injury or the nature of the illness. Depending on what type of call it is, the number of patients is the beginning of the patient assessment process. Before I move on, and I'm sure it's going to be mentioned in the slideshow, I have a tendency to get ahead of my slideshow. Knowing you need further resources is a big part of your initial assessment, and thankfully it's not usually hard to assess that when you've got more patients than you can handle. So you can make that early. Again, maybe redundant after our last unit, but we need to take our standard precautions, whatever they may be, and that's not just gloves and glasses. That's maybe turnout gear. It may be safety glasses, vest, helmet. It just depends on the scene. We need to evaluate the scene hazards and ensure scene safety to the degree that we are able. Please keep in mind that scenes can be very deceptive. They can look very sedate, and there's boogers hiding in the bushes just waiting to get you, of different kinds. And they may not present themselves until the worst possible moment according to Murphy's Law. Determine the mechanism of injury, nature of illness. We're going to establish a number of patients, and we're going to ascertain the need for additional resources. If you're wondering about that, if you're on a scene, if you have to give it more than a few seconds thought, you probably need more resources. It is much better to have a resource and not need it than need it and not have it. So be proactive where that's concerned. Everybody gets primary assessment, even though it may not be a formal one, and I'm not supposed to tell you that because this is textbook stuff, but the fact of the matter is, if I have an uninjured patient who doesn't look like death, who's not bleeding all over the place, who's able to talk to me and give me intelligent answers, no, I didn't open the airway and look, listen, and feel, but I'm reasonably sure that my ABCs are pretty well covered. But the purposes of this is our immediate threat to life scan. This is the things that we look at to make sure that we don't need to rapidly act or they're going to die right in front of us. Is to determine the nature of the problem, as I said, to manage immediate threats to life, and to establish priorities for treatment and transport. There are times, guys, and good ones know this. Good EMTs know this. Good paramedics know this. Good doctors know this. Anybody in medicine knows it. Know when you're over your head. And that usually doesn't take long for you to figure out. Know when your patient has an issue that's beyond me to fix. There's no shame in that. As a matter of fact, I would credit you for it, knowing that this dude's got problems or this dudette's got problems I can't fix. I need to be moving. My best treatment is get them in the bus and roll. Let's talk about the steps. And I did something, and I'm going to take just a second. It really messed me up because I had to redo this slide. I found a typo in the slideshow, so it really messed me. It was a very significant one. They left out the word air and airway. It said assess their way. And that really, I'm like, okay, I don't know what that means. And then it hit me what I'm talking about. But the steps are as follows. Form a general impression of the patient. Don't do a general impression of the patient. They usually find that offensive. I won't do that again. Assess the level of consciousness, which is the mental status. We usually do that in a very cursory way. The AVPU method is what we're looking at here. I'm going to do a fuller assessment of their cognitive abilities, but right now I'm worried about what's going to kill them fast. So I'm going to check their level of consciousness. Assess their responsiveness. I've always had a bone to pick with the assessment of level of consciousness during the primary survey because that's really not what we're doing. We're assessing responsiveness. Assess their airway, primarily making sure they have one. We talked a little bit about assessing airways back in oxygen therapy, so I'm not going to beat that up too much here. Assess their breathing, assess oxygenation, assess circulation, and establish your patient priorities, what you need to focus on. Just to say a word about this, guys, when we say assess, at this stage in the game, that assessment's going to be very general. I want to know they have an airway and that it's not in danger, immediate danger. I want to assess their breathing. I want to know they're moving some air and that they're actually able to do that. We'll delve into that deeper in the secondary survey or the focused exam, if you want to use a more current terminology. I want a general assessment of oxygenation and the general appearance of the patient, the texture of the skin, their general appearance, their look, their cognition. I said we're not going to really evaluate that, but you will pick up pretty quick if they're loopy. And their circulation. I want to make sure that we've got pulses, and I want to make sure that there is really no leaks or big ones that I can see anyway. And once I've done this, we're going to establish the priorities. In other words, if I note on my primary survey that they're having trouble breathing, then I'm going to dig deeper into that and see what I can do about it. I may have mentioned this earlier, but if not, I'm gonna say it now. The only time we interrupt a primary assessment is to correct a problem we found in a primary assessment. In other words, if they don't have an airway, I'm going to open an airway. If they're not breathing, I'm going to breathe for them. If they don't have circulation, well, we're looking at a CPR situation then. And if we have circulatory issues, I'm going to address them immediately. These are, as I said, this is the part of the assessment where we look at major systems that support life, and we fix deficiencies in those systems. We can, there's a lot of injuries. Sometimes they're what we call distracting injuries. They look really nasty, but if these issues, these ABC issues, are not addressed, none of that matters. None of that matters. Yeah, I learned that, guys. It's a big chart. Actually, it's intimidating. It's the algorithm for primary assessment. But really what it's doing is reinforcing what I just told you, and you will know it by the end of this unit. You may not believe that looking at it, because we love to take the simple and make it as complicated as we possibly can, and that's what this appears to do. But it's simply a yes-no chart that dictates your actions during a primary survey. And it basically says that if you have a deficiency, fix it. And I won't belabor this any longer. Forming a general impression of the patient. This is a skill, and it comes with experience, because there's a lot of nonverbal communication and a lot of not really obvious clues to the untrained eye that can give you an idea of how bad off your patient might be. You want to develop a general impression of the patient's condition as you approach and determine if he or she is stable or unstable. Sometimes you can tell by looking. Sometimes you know a patient is not stable before you ever place a hand on them. Just by the way they're laying, their general look, their general demeanor, how they're interacting with their environment. You need to determine the chief complaint. Remember, we talked a little bit about chief complaint. Chief complaint, I'm sure that this slideshow is gonna make me say this again. The chief complaint is what the patient thinks their primary problem is, not necessarily what you think their primary problem is. It's what the patient, it's what they are complaining most about. What is that complaint? And you want to observe the environment. The environment, in many cases, particularly in residential calls, gives you an idea of the overall health status of a patient. You're seeing them in their natural habitat. I don't want to get too much in commentary on that. I've done it in class a few times, and the reason I don't want to do it now is I just don't want to drag this out. But if they're living in an environment that looks like it would be conducive to a healthy life, they probably are healthy. Doesn't mean they are. They could have some really bad habits they keep hidden. But if they're living in something other than that, it should give you a clue as to how well maintained their health status is. Sometimes what you see there will lend itself to the problem you're dealing with. And I'll leave that for now because I'm sure this slideshow is going to bring me back to it. If the patient can't tell you, you need to estimate the patient's age. You'll get better at this. I don't mean carnival level, those people that go around. Maybe you will, I don't know. The patient's sex. There are problems that are endemic to the sexes, more likely in a male patient than a female patient, and vice versa. It's very unlikely, for example, you're going to be checking testicular torsion on a female. If you are, we need to talk. Determine whether the patient is trauma or a medical patient. Some of the most really interesting calls I've ever dealt with were both, but we won't go into that. That's a war story for another time, or war stories for another time. Obtain the chief complaint. Identify and manage life threats, immediate life threats. This is part of forming that general impression. What does this picture say to you? And I will grant you that this is very subjective. This is very subjective. To me, she looks worried. She doesn't look particularly pale. She's kind of leaning on the door. That may imply something. It may imply nothing. We're getting a snapshot here. I'm not really having an interaction with her. I would probably take a lot. I will say that the environment behind her looks very well maintained, well kept. This person is obviously middle to upper middle class, possibly better, which means her health care generally has probably been looked after better than some people. She has access and she has the means for which to do it. I take her to be late 40s, early 50s, possibly. You know what? I'm going to say mid 40s, unless she colors her hair, which we don't know. There's not a lot of gray in that hair, so, and she may color it. Women are more likely to color their hair than men are, although some men do. Just a moment, somebody's blowing me up. Okay. General impression. What does this tell you? I mean, the slide kind of gives it away. I almost wish they would have hidden that. We've talked about this. This is a variant of the tripod position, leaning forward. Sometimes you'll find them standing forward, leaning on their arms, whatever. What else do we see there immediately? Look over on the table. We've got an inhaler there, which he's probably sucked dry, because if you're being called, this person obviously, by virtue of that inhaler, has a respiratory problem and lives with it, and for whatever reason today it's different. These people, as I've told you before, I will reinforce it, are usually very reluctant to call us. They've had to call us many times, or they've had to be under medical care so many times that they avoid it. So something is different about this episode today, and we should always take that seriously. We should always take that seriously. A lot of information. His environment also looks clean. He also looks very well dressed. His health care, we can infer, and we could be wrong. We only got a little bit of time to make these judgments. It's probably pretty good. He probably, sees his doctor and is taken care of. He has the means for it. So there's a lot of information in this particular photo. Oh, we got all kinds of good stuff in this one. We have an obvious injury, and this is the danger. This is the danger, and I'm going to warn you about it. We got a big old gross nasty injury on his leg, and he's bleeding. It's icky. And it's going to draw our attention to it. It may draw us away from what might kill this patient. And we do have bleeding. We have obvious bleeding, and we're gonna have to get to that pretty quick. But as we're approaching, we're not treating yet. We're just approaching, and this is what we see. I see a lot of things. I see a scaffold, part of it, just to the right of the patient. Excuse me, just to the left of the patient. I see a power tool on the floor, a grinder. Was he on that scaffold? Am I looking at a fall here? It's kind of hard to gauge the level of distress just from the face. He doesn't look happy, nor should he, really. We have a lot of potential for what could have happened here. We also have some safety issues because this looks like a construction site, which you need to keep your head on a swivel when you go into those. He's not wearing a hard hat, but I'd still would worry about somebody dropping something on my head. I'm going to stop there, but what caused him? If he fell, what caused him to fall? I'm going to go out on a limb at first glance and say that grinder is not the source of that wound, because I don't see any blood on the grinder. I'm not even sure he was holding it when it happened. Could have been. You never know. We'll find out as we move through this call. I mean, we may not find out about this particular picture, but if this were a real call, we would find out as we went through it. Unresponsive patient who is likely suffering from a medical condition, but for whom trauma cannot yet be ruled out. And you see a lot of these. Population's getting older. You're probably sick of hearing me say that too. We deal with a lot of geriatric patients. Geriatric patients are a particular difficulty for us and for doctors. I don't want us to feel picked on. They're difficult for doctors and nurses too. They don't present typically. They are likely to have extensive medical histories. They're likely on a lot of medications that play with and against each other in this patient. And frankly, their compliance with their medications is often sketchy. Sometimes, I can't tell you how many geriatrics that I have found who over-medicated themselves. They got confused about whether they took this medicine or they didn't, so they take it twice. You will be amazed at how many I have found with problems because they had not been taking their medication. So all of these things come into play. I see a gentleman laying left lateral recumbent. I have no idea how he got there. He's far enough away from the bed that I wonder if he fell out of the bed. Usually they're laying right beside of it. Could have, though. Can't rule it out. I see what looks to be a medication bottle on the nightstand. Can't really tell if we've got hip problems here because we can't really see the legs that much. What I do know is he's unconscious. So my primary concern is those ABC issues. And in this case, C-spine, because I don't know what happened. I have no idea what happened. I don't have any obvious injuries, but this is a mystery. This is where we get to play medical detective and try to figure out what happened, and we need to do it quickly. But first, we need to make sure he's got an airway, his C-spine's controlled, he's breathing, has circulation, he's not bleeding anywhere. That's our first concern. And we'll dig through the rest of it to get an idea of what happened. Or we won't. I mean, there are cases where you just don't know. I found this dude laying in the middle of his floor. He's out like a light. Doesn't appear to have fallen, but he can't rule it out. And his blood sugar's fine, and I don't really see any signs of a stroke, at least overt. It's a little hard to pick out signs of a stroke in an unconscious patient. Very well could be, but his vitals may reflect a stroke. But his pupils, he open those eyes and check those pupils. His pupils may reflect the stroke. We just need to dig into it more. But first, I want to make sure that nothing's going to kill him in the next few minutes. Introduction to spine motion restriction, self-restriction. We do this a lot. Sometimes aren't even aware we did it. When we tell patients, I do it. I know I do it a lot. Even when I've got them in a C-collar, I tell them this because, as we both know from playing in class, those C-collars don't stop somebody who wants to move their head around. Be frank with you, neither does the head blocks on a long spine board. So I'm constantly reminding patients, be very still, try not to move your head. Matter of fact, that's what I tell them the C-collar is. Yes, it's going to remind you not to move your head. And that seems to work pretty well. No evidence of injury, place the patient on the stretcher. Evidence of injury or unreliable patient, go for your C-spine immobilization. This is not radical. It's been around for a while. For us old dogs, it's still hard to accept. We used to board everybody. The ubiquitous phrase was, you don't have x-ray vision. And it's still true. I don't. So if there's any doubt in my mind, any at all, they're getting boarded. They're getting spinal immobilization. There are many times I'm very comfortable with saying, nah, they don't have a spinal injury. Never 100% comfortable, but comfortable enough to not go through the spinal restriction procedures. If you've got no evidence of injury, place them on the stretcher. If you have an evidence of injury, unreliable patient, apply the C-collar. Patient can also be placed on a backboard or a vacuum mattress, which really I would rather use. A backboard is very uncomfortable, and my brain is still lingering over the gentleman laying in his bedroom floor. It's particularly uncomfortable for the elderly. So I try to avoid that. It's acceptable nowadays to kind of do a little bit of one, a little bit of the other, put them in a C-collar. I'm really of the school that says if you're going to immobilize. If you're not, don't. So if I'm going to put somebody on a stretcher, I'm not putting them in a C-collar. I'm not going to put them on a board. If I'm going to clear that C-spine, I'm going to clear that C-spine. If there's any doubt in my mind, they're getting boarded up. It's a workable standard, one that I recommend that you think about real hard, because if there's any doubt in my mind, kind of a pet peeve of mine to see someone in a C-collar on a stretcher with nothing else. And my thinking is, well, if you're concerned enough to put the C-collar on them, why not go all the way? Or leave them off. Do one or the other, but don't try to do half of both, because it just doesn't work out very well. Patients found in unusual environments or circumstances are difficult to categorize. You don't have any idea how they got there. This is a good picture for that. We've got this person out in the middle of it. Looks partially paved. It's got bushes around, boxes around, debris around. And we don't know how they came to be there. It's very hard for us to categorize them. These are a special problem, especially if they can't talk to you. If they can talk to you, you can nail it down reasonably quick. What happened? How did you come to be here? They may be able to tell you. When they can't tell you, then we have to dig a little bit deeper. And we do have to think about, well, this could be a trauma call. This could be a victim of assault. This could be a substance abuse call. This could be a stroke. This could be any number of things. We found them out of an area that gives us a lot of clues. We just found a person in an unusual environment. We do this a lot too. A lot of times, in many places, it's standard procedure for law enforcement when they find someone like this, whether they see an injury or they don't, go ahead and call us, just because they've got a person laying out in a weird place where they're not supposed to be. So we end up evaluating these people. On that note, I'll say remember to use all your resources. Law enforcement, I need to know what they saw or how they came to find them. Briefly, I don't need a long story. I just need to know that. I need to know what they see. And I mentioned this in class, and this is pretty true here in North Carolina, particularly in rural areas. That these deputies know everybody. I mean, these local police officers and these deputies, some of them lived here all their life, and they know everybody. So they may be able to tell you something about this person. They may have seen them before. They may know who they are. They may be able to give you some insight. We're still talking about a primary survey, so I don't want to get lost in that. I'll have to repeat it again later on in the slideshow. But I do want to say our ABCs, our primary assessment, needs to be geared defensively until we have an eye on what's going on. I don't know how they came to be there, but I'm going to expect everything when I go through that survival suite, make sure we've got all our major systems intact, including the C-spine. See a lot of this. Even an unconscious patient, sometimes they'll give you clues, like a scar in the chest that tells me this person has had surgery, major surgery, probably bypass surgery. I can't imagine any other reason to have an incision there, but I'm sure a surgeon could give me 100 if I ask why you might have one there. That's where my thinking would go. Particularly, this is a male patient, and look at his age group. I would put him in his mid-50s, early 60s. It's hard to tell with that reservoir in front of his face, but just looking at his general build and the gray hair and everything else, that's where I put him. He's the primary candidate for it. Looks a little bit, he's not really overweight, but like most of us, when we get to a certain age, we carry a little more extra weight than we need to, whether we like it or not. So yeah, they will give you clues. They will give you clues as to their medical history. Sometimes you'll find a dialysis shunt in one of their arms. We'll talk about that a little bit more later. Determine whether the patient is injured or ill. Injured, penetrating trauma, and these are just two principles. They're very important. They all each have their own specific concerns to us that we'll continue to go into. Penetrating trauma is force that pierces the skin and body tissues. Literally, it penetrates. Blunt trauma is caused by a force that impacts the body but doesn't penetrate it. You know, I talked a little bit about this in class. If you'll remember, I talked about force. And physicists tell us that force can either be created or destroyed. It's set in motion and absorbed. And absorption of force on the body is what we call trauma. And blunt trauma can be every bit as dangerous as penetrating trauma, even more so in some cases. It all depends on the nature of the call, the nature of the force, and the part of the body that was contacted by it. The environment may offer us clues that the patient is suffering from a medical problem. We talked a little bit about that on some of the pictures that we saw earlier, and I'm sure we'll be coming back to more of those. Categorize this patient as being injured, a trauma patient or a medical patient. Well, quite frankly, this one is, to my mind, I'm sure that paramedics, being an argumentative bunch, I could line up 5 of them, we'd all get a different idea about this, and we'd what if it to death. But just looking at it on its face, I see blood. And I don't see blood in the mouth or the nose or the ears. I see it way down in his belly and his shirt and running off to the side. So it don't look like he threw it up, which could be a medical issue. So to me, this looks like it's got trauma written all over it. It'd be kind of hard to classify it as anything else. That doesn't mean there aren't other things wrong. It doesn't mean it doesn't have a medical problem. But my primary thought right here is this is a traumatic incident. Trauma or medical. Looks can be deceiving, but this one screams medical to me. I don't see any obvious injury. We could what if this one to death too. What if he fell and caregivers put him back in the bed? Well, it's possible. Could be trauma. But I don't see anything, and that's not what this picture says to me, just looking at him. And this is when we talk to patients, guys. I told you, a good friend of mine once made the statement, a fellow instructor who said if you talk to patients, they'll tell you exactly what's wrong with them. Talk to them long enough. There's a lot of truth to that. And I'm going to interview this guy. We'll find out what happened, but just my impression, and that's what we're talking about here, general impression is that this is a medical call. The chief complaint, and I had said the chief complaint is what the patient thinks is wrong, and I stand by that, but they have another roundabout way of looking at it, and that is why were we called? And that's good. I don't have a beef with that. It's a good statement. They usually will be the same thing, I imagine. Don't assume that the original complaint is the true chief complaint. I'm not going to try to second guess the slideshow. I think they might be trying to say in the slide that what I had said earlier, don't assume that their complaint is the primary complaint. their chief complaint is their primary problem, not by a long shot. Being amazed at how many people get that wrong in both medical and trauma situations. Trauma patients may have an observable chief complaint. It's true, but you can also be surprised. I've actually had a patient that immediately comes to mind who had lost his arm, a traumatic amputation in an MVA, but his chief complaint was a broken tib-fib, which to me wasn't nearly as serious. That was the chief complaint. That was his chief complaint, but it wasn't what I thought was his most serious problem. So sometimes the patient's not the best judge of what's really wrong with them, but their chief complaint is very important. I want to know what they think is wrong with them. You're always going to want to get a chief complaint from a medical patient. It's the last bullet on that slide, and otherwise you're not going to go very far. If you don't know why you were called there, you're going to have a lot of work to do. It's always best to start there. Let's talk about some immediate life threats that may be obvious, may not be, during the general impression. An airway that is compromised by blood, vomit, secretion, the tongue, bone, teeth, anything that's obstructing an airway is an immediate life threat. Even if it's not blocking it completely, it's a warning that your airway is in jeopardy. And what did we say about the airway when we were talking about it in class? We have to aggressively secure that airway. It is paramount. Obvious open wounds to the chest. Yes, we've talked about this quite extensively too, although in an off-the-hand or off-the-cuff way, when we talked about breathing and we talked about how the chest is a pressure chamber, it needs to remain so if you're going to have normal breathing. So an open wound to the chest has compromised my pressure chamber. Sometimes the open wound doesn't penetrate into the chest cavity. Sometimes it does, but it's always a red flag. Paradoxical movement of a segment of the chest. We talked about this. This is a flail section where you've got inward movement on inhalation and outward movement on exhalation. This also signals a compromised pressure chamber, which is the chest. Major bleeding. Steady flow, maybe venous bleeding, spurting, probably arterial. You can bleed out very quickly. If you've got major bleeding, you need to stop it. You need to at least, most of the time you can stop it, but if you can't stop it, do your best to slow it down. A patient who's unresponsive with no breathing or no normal breathing. We also talked very extensively about agonal respirations, where reflexively the body is going through the motions of trying to breathe, but no air is moving, or very little air is moving. Forming a general impression of the patient. We've already talked about this. These slides do get redundant. We want to identify immediate life threats concerning the general impression. Cardiac arrest must be recognized immediately when we immediately begin our resuscitation by chest compressions, opening the airway, providing ventilations, and early defibrillation. Get that AED quickly. There's really funny, and I've seen many evolutions of advanced cardiac life support through the years, believe me, more than I care to think about. And it's really come full circle. It's come back. We went through a period where we were just loading massive drugs in these patients, as a matter of course, in a certain order. And yes, we were defibrillating, but it was not primary, really. It was, we did I remember one iteration was we would do stack shocks, and then we'd give epi, and then we would, circulate and shock, and then we would give, it's come full circle. What we know, and what American Heart Association knows works, is good compressions done immediately, or as close to immediately as you can get after they collapse, after they go into cardiac arrest, and early defibrillation. Those two things work, and we know it. Everything else is up for argument, but I think they've finally come back to that very basic principle. Good CPR, early defibrillation. Perform spinal motion restriction. If you suspect a spinal injury, then we grab that head. Remember? We did it in class. Take the head and hold the head. And it's a good idea if your patient's conscious to tell them that you're just not doing that because you want to feel their head. You need to tell them, I'm doing this because I don't want you moving your head. This is just me reminding you not to move your head. Inline stabilization, place one hand on each side of the patient's head, bring the head in an inline position, place the head in a neutral position. So we want to make sure we address a suspected spinal injury immediately. It's right up there with airway. And here we see a picture of it. One of the EMTs in this picture, the young lady on my right, on the patient's left, is apparently doing a secondary or a head-to-toe sweep. And we have one EMT at the head whose only job at this point is to maintain the C-spine. The self-restriction procedures instruct the patient to bring his head and neck in line with the umbilicus, instruct him to keep his toes in line with his nose and navel. That's interesting. Instruct the patient not to move his head or neck until given further instructions. That's spine motion restriction. I was going to let it go, but I got to say this. Giving patients instructions and having them follow them is dicey at best. Dicey at best. If I'm concerned about their C-spine, I'm going to maintain their C-spine. If I'm not concerned about their C-spine, I'm not going to worry about it. It's really it's not a rheostat, it's an off or on switch. Either I am or I'm not. And I'm going to take the appropriate actions, or lack thereof, depending on what I decide. Position the patient for assessment. Sometimes, and we talked about this in class too, sometimes it is perfectly appropriate, even necessary, for you to get this patient to a position and a place where I can actually see what I'm doing. You know, yes, you have to be cognitive of a possible spinal injury. You have to protect the C-spine, but people can get themselves into spots where I just can't examine them any other way. I've got to move them. I've got to get them over. And this slide says, if necessary, log roll the patient after quickly checking the posterior body. And use inline stabilization if spinal injury is possible. Just reiterating what I've just said. It's perfectly appropriate. You know, you've got to be able to get to the patient in order to treat the patient and have access to the patient. The next of these slides are demonstration slides, and we have done some of this in moving patients. I went ahead and taught you some of this, but they just give you a good illustration, and I'm sure there's other illustrations in your book. These probably will be better looked at in lab, and we certainly will again and continue to reinforce them. Did a little bit last lab, had a good time with that, a lot of fun with that, but let's continue with them. This is kind of interesting. I don't think I've had you do this in class yet. I think everybody that we've had has been supine. This is a prone patient, and you see probably the most important part of this is they are still, he's holding the C-spine in the position found, and he's got his, and remember, he's at the head, so he's going to be calling the shots here. And then they get their grasp. Note the medic to the anatomical left farthest, down toward the feet. Look where he's grabbing. This is what I talked to you about. And look at his partner right next to him. Belts are wonderful. If they're a good sturdy belt, they're patient handles, and you need all those you can get. And they rolled this guy over. They rolled him over as a unit. What it appears to have happened here is, although he was holding the head, the one at the head here was holding the head in the position found, when they rolled the patient over and the head was in a neutral position, he went with it. He put the head in a neutral position and then put the patient on the board. Not a lot to see here. We've done it, so I'm not going to dwell on it too much. And just another view of it, guys. Notice that we've got inline, the head is inline, it's being supported, it's being controlled at all times. Well, let's check in with our EMTs and our ladder case here. What happened, asked Della as they quickly walked around the side of the house. My brother was on a ladder cleaning out the gutters. The patient's sister replies, I had my back turned and I heard him hit the ground. He landed just like you see him. Okay, we got something to go on here. Della notes that the house is single story. Looks like the patient fell about 6 feet from his position on the ladder, landing in a grassy area. So we've got our surface, and we've got an estimate of our height. The patient is lying prone on the ground and is not moving. Carrie pulls on his gloves and asks, what is his name? Bob, the woman replies. Name's Bob, which means his real name's probably Robert, but it could be Bob, just Bob. Carrie places a hand on Bob's shoulder. Bob, can you hear me? Bob does not respond to Carrie's voice or to Carrie squeezing his trapezius muscle. No response to pain. I just thought of something else silly I was going to say, but I'm not going to. No response to pain, Carrie tells Della. I will stabilize his head and neck. Let's log roll him. Now, they're going to do a two-person log roll because we don't know if anybody else is on the scene. What are some particular concerns with this patient so far? Well, let me read all the questions, and if you want to sit and contemplate it without me yammering over it, you can. You can stop the recording. What should Della and Carrie do next? What equipment should the EMTs be prepared to use at this point? This is tough for me. I've got a picture of it in my head, but I guarantee you the picture in my head probably is not going to match the picture in yours. Some of the particular concerns with this patient so far, well, he fell from a pretty good height. He's not responding to me, which suggests to me some type of neurological deficit. How bad, we don't know. Did he just get his bells rung and or does he have a brain bleed? I mean, it could range anywhere in between, so we don't know. He fell on grass, which is probably the best he could hope for, 6 foot height. And also what's popping into my mind is what made him fall? Did he just slip? Now, we know he's a diabetic. They mentioned that. So I'm kind of curious about that. I think that's an interesting detail of this so far. And what should Della and Carrie do next? Well, they seized the C-spine, as they should. They're going to have to roll this guy, probably, to get him on his back. And I would think their next course of action will be to proceed with the primary survey. Prime candidate for it. He's unconscious. He's not responding to them. So they need to very quickly assess those vital systems to see if we've got an even bigger problem than we know. And what equipment should the EMTs be prepared to use at this point? You should be able to answer this one completely. I've kind of beat you up about it. Hopefully, they've got, a long spine board, a C-collar, head mobilizer blocks, and straps with them because they're going to be needing them. I hope they got a suction unit with them. This guy's unconscious. He may not have suction equipment, airway adjuncts if necessary. The deficit in his LOC would lead me to think that he's a prime candidate for oxygenation. And that's just to get started. We don't know what they're going to find as they continue to examine this patient, but they need a bunch of stuff. If you were keeping up with that list I just gave you, that's a lot of stuff. But hopefully they've got it handy. And I probably forgot some. I'm running through this kind of quick. Assess the level of consciousness, the mental status. And we do this quickly in a primary assessment. We're just trying to find out their responsiveness. Yes, the slideshow caught up with me. Consciousness is a little bit deeper. Consciousness is a different animal altogether. Right now, I'm just trying to get an idea if they're responsive or if they're not to voice or not spontaneously conscious when I get there, what will arouse them, what will get a response from them. Alertness and orientation. If the patient's eyes are open, he can speak as you approach him. You might assume that the patient is alert. Not a bad assessment to make right off the bat. We're going to, as I said, as we talk to this patient, we're going to get more insight into that. A patient can be alert but agitated, confused, or disoriented. Those are important things to make note of. Just kind of hang a little post-it note in the back of your mind there. Of course, we talked about this in class. The ABPU, alert, means that they're spontaneously awake, I guess you could say. They respond to, if they come around when you call their name or shout at them, whatever, which I would recommend you do sparingly, then they are responsive to verbal stimulus. If it takes a shake, if it takes a squeeze the trapezius, as our EMTs did, sometimes we'll result in something called a sternal rub. We really haven't talked a lot about that except to acknowledge its existence. I may have briefly demonstrated it. We'll talk more about that in lab. Or are they completely unresponsive, meaning nothing I do gets a rise out of them, period. They're out of it. And this is just going to recap what I just said. Responsiveness to verbal stimuli, they open their eyes, responds, or attempt to respond to your voice. If the patient does not speak, see if he'll follow a command. That's good advice. If they open their eyes but they don't say anything, ask them to do something. Lift their hand, whatever, to see if they follow a command. And if they, going back to our case study, and I shouldn't because these are general principles, but that patient, if he opened his eyes, and I'm not saying he will because I don't know where the case study is going to go, but if he opens his eyes but cannot speak, given the nature, given the mechanism of injury, and the patient's history for that matter, what little we know of it, that's an important thing. That's a very important thing. That would lead me down the path of, well, did he have a stroke? Does he have a head injury? Is his blood sugar low, which is not impossible that it was a blood sugar problem. And I have seen people that look at you with a blank stare and don't speak when their blood sugar is low. It could be any of those things, but it's an important detail in the context of the case study. But it's an important detail in general. The patient does not speak, see if he'll follow command. Painful stimuli, if he doesn't respond to verbal, try a painful stimulus. And I probably just cut myself off because I was talking when I flipped the slide, so forgive me. Assess the level of responsiveness, back to painful stimulus. Methods of applying painful stimuli include trapezius or an armpit pinch, supraorbital pressure, very careful with that, sternal rub or earlobe pinch, nail bed pressure, pinch the webbing between the thumb and index finger. You're not trying to hurt people, but you are trying to cause them just a teeny little bit of discomfort or stimulus. How they react to that, which is probably my next slide, so I'll stop and move on. Now, this is just going to show you some methods. Doing the Vulcan neck pinch here, which is interesting because I thought that would knock you out, but it always did on Star Trek anyway. I'm going to go ahead and say what I didn't say on the last slide, if I can remember what it was. How they respond to a painful stimuli can be important as well, and that goes back to a much deeper assessment of their neurological status. Do they withdraw from it? Do they purposefully bat you away or bat your hand away, or do they simply withdraw from it? Do they do something that really seems weird for what you did? In other words, if I'm pinching them on their thumbnail, do they extend their arm rather than pull away from it? These are all important things that could be factors in their neurologic status. There's the supraorbital pressure. It's effective. The eyes are very sensitive, and most of the time, if you've ever got an eyelash in your eye, you know how that is. The eyes are very sensitive, and anything that messing around your eyes usually will get some type of reaction out of you, even if you don't mean for it to. And he needs to trim his nose hair. Anyway. There's our sternal rub, our old friend, the sternal rub. You just kind of take your knuckles and move them back and forth. Not crazy hard, not enough to, but you need to put some pressure on there and rub back and forth, which you can't see in the picture. And that will, see if that elicits a response from them, any type of response at all. That's a sternal rub. Notice in this picture, and this is back from a few pictures back, this was our guy with the leg injury that was in one scaffold. I recognize him, and I recognize the surroundings. Probably in a continuation of pictures, but he's holding C-spine. Referring back to the last picture, sometimes if you've got the head, you got the best job there. All you got to do is hold that head. That's your job. You got one job, Carl. Hold the head. That's what you do. Call rolls if you have to roll them. Call the roll. Call the move. And this is an earlobe pinch. All these look rather sadistic, but they're not. They're not meant to be. And keep that in mind when you're doing them too. And I knew that me going ahead and saying that was going to bite me, because here comes the slide. Responsiveness to painful stimuli. Responsiveness to a painful stimulus is typically purposeful or non-purposeful. And that's what I was getting at. Movement toward the painful stimulus as if to push it away is purposeful. It's a normal reaction. Movement away from the stimulus would be withdrawing from pain. Flexion or extension, posturing, are abnormal responses. This is a lot like trying to describe posturing. It's easier for me to show you than to tell you. I guarantee you won't forget it if you ever see someone really, to the degree that it can be done, posturing. It will stick with you. It's kind of frightening, actually. But I don't think they mean the type of posturing I've got going on in my head. I think they're talking about if that move that I told you about, if I'm pinching them on the thumb or whatever, and instead of pulling away or pushing away, they simply extend their arm, and it doesn't look to be a purposeful movement at all. That is significant. That means something. Full-on posturing, and I'm talking about decorticate or decerebrate. We'll talk about that when we get into head injuries. That you won't forget when you've seen it. You won't forget because you're getting ready to see it. This is decorticate posturing. And believe me, the picture doesn't do it justice. I have seen people arch their back to the point they come off the floor when they're posturing. It can be quite violent. And that's why I say you won't forget it. But notice, and if we get them mixed up, people always get decorticate, decerebrate. Think of decorticate toward the core. Look where the arms are. She's pulled them in. They're tucked up under her chin, and there's the lower extremities are medially rotated. I'm not going to go any farther than that. I'll see if I can pop up some video or links to some video that shows you this, if I can find it, the real thing. It's something that stays with you. Decerebrate posturing. We usually associate these two things with a severe insult to the central nervous system. The brain is really pissed, and it doesn't like what's happening, and it's letting you know about it. Same thing with seizures, but this is actually worse. It is very rare, I can tell you, that I have seen hypoglycemic patients posturing. Their brain's annoyed too, big time. Their brain is, it can only get sugar from the blood, and it's not getting any, and it's going to let you know. It'll shut down for one thing, and it may show you this. So just because you see it doesn't mean all is lost. But I got to tell you, people that are doing this, prognosis is, let's just say it could be better. I'm not saying they're going to die. I'm saying they very well could. They've got a severe insult to the central nervous system. I think what I'm going to do is I'm going to finish up these responsiveness discussions here, and we're on still on painful stimulus, and then I'll wrap up part one. Problems with some type of painful stimuli. I always assess the central painful stimulus. Peripheral stimuli may reach the spinal cord, but not the brain. this is now we could get into a big long discussion about interneurons and axons and dendrites and everything else, but basically I think what they're trying to get to here, and I don't want to go down this rabbit hole. Basically what they're telling you is that some actions are reflexive. They do not reflect purposeful movement. If the interneurons are still working properly, it's the same thing when you touch a hot surface and your hand automatically pops back. You don't have to think about that. It's a natural reflex to do that. Excuse me again. So you need to assess whether that is a purposeful movement or a non-purposeful movement. I think that's what we're trying to get at here. It's a little bit confusing, even to me. An unresponsive patient who does not respond to verbal or painful stimuli. Unresponsive patients are a high priority for emergency care and transports. They really are. Because the culprit many times is that insult to the brain that I talked about, from one of several causes, all of which come around to some of the same territory. That is, the brain is not happy at all because its blood supply has been interrupted, or its glucose supply has been interrupted, or blood is pouring into that very closed space and putting pressure on it. Unresponsive to verbal or painful stimuli can indicate the patient's inability to maintain his airway. Always a concern. Always a concern. Document the level of responsiveness. Be specific when you're documenting the level of responsiveness. You need that baseline. One of the most important, it's a very simple concept that when we talk about head injury, we talk about central nervous system issues. One of the best indicators of how bad something is a description of what they cannot do that they normally can. And also, when you have a patient that may have an insult, what they could do that they no longer can do in the course of your treatment. The trend is very important. When I got there, they were able to talk to me, and now they're mumbling and I can't understand them 15 minutes later. Well, that's very important. That's good information to pass on because it denotes that this person's degenerating and also gives us some idea how fast they're degenerating. The AVPU check is performed to quickly establish a baseline for mental status, which is a summary statement. Basically, that's what we're trying to do. Now, I'm going to stop here for part one and go ahead and render this. I'm not going to do a lot of editing in this one. I'm just not. Don't have time for it. I doubt very seriously I'll get part two up today. I wanted to get this one started. Remember, I don't usually do, or don't anymore, do a lot of video lectures. So if you have questions, remember, I should have said this at the beginning, write them down and bring them to me, and we will discuss them. But I'm going to end part one right here, and I'll see you for part two.